Good afternoon and good evening, everybody. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. Before we begin, I want to acknowledge briefly that this is a moment of sadness for our community. Our beloved colleague and friend, Dr. David Jones, Associate Professor in our Department of Health Law, Policy, and Management, passed away over the weekend. David was a much beloved member of our community. His loss is truly devastating. It's difficult, perhaps impossible to know what to say at actually such times, but our thoughts are with his family and loved ones at this time. Resources are being made available for students, faculty, and staff toward the coming week, and we'll follow up in the coming days with details for a memorial to celebrate David's life. Meanwhile, we will follow the sentiment expressed by David's wife, Sarah, on Facebook last evening. I quote, "We must go on carrying the light he gave us, drawing strength from your memories." So it's in that spirit, drawing light from those in our community who have passed, who have taught us very much, that I welcome everybody to today's event. Welcome. Thank you for joining us. Before we begin, a word of thanks to our co-host, the Consortium of Universities for Global Health, and a thank you to our organizers on our end, Meredith Brown and Alicia Noel. Thank you. This year marks our school's 45th anniversary. The theme we have chosen for the year is Public Health Now is the Time. To mark the occasion, each month we have elevated an area where our community's expertise intersects with the priorities of public health. This month, the theme is Global Health Now is the Time. There is a new, burgeoning, interesting scholarship about the evolution of global health, including thinking about the decolonized movement in global health and a greater appreciation of the need to ground global health thinking in population health science. I am looking forward to hearing those ideas emerge in our conversations today. In our programming, we are engaging with this theme by featuring the work of our Global Health Department, the global health work of our broader community, and through our programming by bringing experts like the ones today. Today is also the first event in our next normal series of public health conversations about how we can shape a healthier world post-COVID-19. The pandemic tested public health like nothing before in recent memory. The task now facing our global health efforts is to reimagine our world in light of the lessons we have learned to shape a healthier future. Today's event aims to explore how we can do so, focusing on global health. Thank you to our distinguished speakers and to you, the audience, for joining us. It's now my great pleasure to turn the event over to an esteemed colleague and a friend, our moderator, Professor Mohammed Zaman, Howard Hughes Medical Institute Professor of Biomedical Engineering and International Health here at Boston University. Professor Zaman.
Thank you so much, Dean Galea. Thank you, colleagues, for joining from around the world and different time zones. I also wanted to sort of reflect on the passing of a dear colleague, and it's indeed a very challenging time. But as Dean Galea mentioned, the work has to continue in memory as well as in the effort that our colleague really sort of brought to the fore. It's an absolute pleasure to be part of this event today. Thank you for having me, and thank you for giving me the opportunity to introduce our colleagues. Just to give you a sense of the format, I'll introduce all of the colleagues right now, our esteemed speakers. They'll speak for about 8 to 10 minutes. In the meantime, if you have questions, please type them in Q&A. I'll collate them and collect them, and we'll ask them at the end. First, we will hear from Dr. Conley, Elongate, Assistant Professor of International Health at Johns Hopkins University. Dr. Elongate has a broad interest in global health with a focus on implementation science, health systems, and injuries. His research objectives are focused on improving the delivery of quality health services to disadvantaged populations, implementing and scaling up of effective public health programs, and reducing the burden of injuries in low and middle-income countries. Then we will turn to Dr. Luke Ley. Dr. Ley is an associate clinical professor of medicine and pediatrics at University of California at San Francisco, where he is a hospitalist, splitting his time between both departments. He co-directs the Global Health Hospital Medicine Fellowship at UCSF. He's also an assistant professor at the University of California, Berkeley School of Public Health. Most recently, he co-founded the HEAL Initiative, an interprofessional 2-year global health delivery fellowship. Third, we will hear from Dr. Elena Egedo-Quagle, an associate professor of the Saw-Seek Hawk School of Public Health in Singapore with a parallel position at the London School of Hygiene and Tropical Medicine. She's also an associate fellow at Chatham House, the Royal Institute of International Affairs. She has conducted research on health policy and health systems in Europe, Sub-Saharan Africa, and currently with a focus on Southeast Asia and Latin America. Finally, we will turn to Dr. Maria Niera, who since 2005 has been the director of the Department of Public Health and the Environment at the World Health Organization. She has been working for the WHO since 1993, with her first assignment being the coordinator of the Global Task Force on Cholera Control, and then being appointed in 1999 as director of the Department of Control, Prevention, and Eradication. Among many distinctions, Dr. Niera has been awarded the Médaille de l'Ordre du Mérite National by the Government of France and the Spanish National Nutrition Strategy Award, the Mujer Extraordinaria Award by Queen Letizia of Spain. She is currently a member of the Royal Academy of Medicine, Asturias. Dr. Elongate.
Thank you very much, Professor Zaman. And I would like to appreciate again the organizers for this opportunity to speak to this audience. And I'm going to share my slides so that you could track along with my presentation. Today, I'm going to be talking through some of the issues in COVID as it relates to global health. And I will specifically be addressing two questions. The first question is really the lessons that we've learned from COVID with respect to global health. And then the second question is really around what is the pathway forward? How can we take those lessons forward? The first thing to highlight is that history has taught us over the years that perhaps one of the most important strategies for addressing any global health issue is multilateral and cooperation and collaboration. That is to say, when people come together at the global, national, and subnational levels, and we actually work with the principle of cooperating to find solutions to common problems. That perhaps this is the most important strategy for addressing global health, specifically health issues that or threats that disregard national borders. And we can look back to the Spanish flu, we can look back to other health shocks like war, to think about the emergence of institutions like the United Nations and the World Health Organization. And even in recent times, we can think about the global alliance that have been formulated around specific health issues, including polio, that has a global threat across the world. Now, this multilateral cooperation and collaboration is also needed for addressing global health disparities. By disparities, I mean specifically the disadvantages that disproportionately affect populations in low and middle income country settings, and also unjust health differences more broadly across the globe. Without having a platform where we cannot collaborate, where we cannot talk and build consensus, it's nearly impossible to address the proximal and the distal causes of health issues and of global health inequities. So what has COVID shown us over the last 2 or 3 years? The first is that we've seen the resilience of the human spirit and the heroism of individuals and health workers. I mean, obviously we know that human capacity to respond to challenges is unlimited, and you only discover that as the challenges come. But specifically with respect to collaboration and cooperating together, which is crucial for addressing inequities and addressing pandemics like the COVID, we've seen the willingness of the global community to collaborate and cooperate, especially in competition to address what I call the proximal causes of the pandemic. That's a framework that I use often to think about immediate causes of diseases, for instance, the infectious agents, and the distal causes of diseases, for instance, the environmental determinant, the socioeconomic determinant that influences the choices that people are able to make that put them either at risk or ameliorate the risk of illnesses. So we've seen in COVID the willingness of countries to share science and knowledge and innovation around vaccine technology, digital technology, and around pharmaceuticals. The speed at which the Chinese were able to release the genetic code for the SARS-CoV-2 virus, I mean, enabled a lot of other scientists across the globe to develop vaccines, really leveraging existing resources in vaccine technology and advancement that has been made in genetics over the years. And this is really exemplary indeed, and it's something that should be commended. But at the same time, we've also seen the limited willingness. I mean, the community, global community is less willing to cooperate and to collaborate when it comes to addressing some of those distant causes. For instance, some of those social, economic, and environmental determinants that led to the emergence of COVID, some of those geopolitical tensions that exacerbated it or further worsened the limited capacity of communities across the globe in responding adequately. Rightly put, the co-chairs for the Independent Panel for Pandemic Preparedness and Response did say that we failed in our collective community to come together in solidarity to create a protective web of human security. So what needs to change moving forward? And I'm hoping that we'll talk more about this in the conversations that would ensue. We need to imagine how multilateral cooperations and collaboration is done for the future. The solution of yesterday cannot carry us forward into the future. The institution as it is right now needs to be remodeled even for the contemporary problems and to also be looking forward to the problems that may emerge in future. Specifically, I'm talking about redefining the terms of global cooperation. We don't just need to delegate functions and mandate, we need to give power for people to be able to execute those functional mandate. Specifically to address some of those determinants, and more specifically for COVID to address, or COVID or pandemic-like illnesses to address pandemic preparedness and response. Imagine a scenario where we have an independent committee that has political mandate and power to be able to get data in real time from surveillance and act upon the data and really disseminate information and recommendation at different levels. Imagine what will happen. Imagine a scenario where we have committees in place that are really intently looking transparently at the socio-political determinants of illness and some of the environmental determinants that leads to emergence of zoonotic diseases. I mean, it will create for a more responsive global structure. There's other pathways to consider in addressing the threat of future pandemics include really thinking about how to strengthen the multilateral cooperation and collaboration, not just in competition, but truly in solidarity, and strengthening global institutions with mandates and power to address pandemic. And global cooperation in science and technology will continue to play an important role. So it's really important for us to depoliticize science. The scientific process, I mean, should be independent. The independence of that should be preserved. Scientists across the globe should be able to collaborate and should be able to make the best decision based on knowledge, and that should be the most important factor for guiding science and scientific processes. And we really need to face up to the challenges of our era, that we live in an era of infodemics, and we need to confront those misinformations, the disinformation in all forms. We really need to be proactive to strategize within communities and within populations to make our population more well-informed, to develop more well-informed global citizens with education and communication. And this will serve to purpose, at least in the immediate frontier. The first is really for people to make well-informed decisions for themselves, for their community, and then to also hold leaders accountable at various levels. This is where I will stop, and hopefully we would have more time to discuss on some of these issues as we go on in the conversation. Thank you. I'm going to turn it over to my colleague, Dr. Lee, who is going to have the next presentation.
Thank you very much. Just put my slides up. Well, good afternoon. Thank you so much for inviting me. It's a great honor and a privilege for me to be here and to learn with you all. I'll just first start with a brief land acknowledgement. I'm sitting here on stolen Ohlone tribal land. And if you are a settler on unceded land, you can feel free to go to this website, nativeland.ca, to really start learning about the stewards for hundreds or thousands of years of the land and how to relate to that land in light of their stewardship and what our responsibility is. Okay, well, these questions are big ones, and I definitely don't profess to have any easy answers at all. What are the major lessons we've learned during the COVID pandemic? Then what is the next normal for global health? And for me, it's global health equity. I think the lessons that I've learned are essentially very similar lessons that we learned over the past several decades in the global health space. From the start in 1978 of the Almaty conference, where over 100 countries came together in Kazakhstan and spent some time together talking about primary healthcare, essentially talking about universal healthcare and what that could look like. And they had at the end of that conference a declaration called the Declaration of Almaty. That was about 40 years ago now, and we are quite far away from that vision. And so the question that I teach my students is, why was the vision and the Declaration of Almaty not ever realized? And that's one of the lessons we're learning again and again. And that lesson is, in my mind, a deficit thinking. Some people call it a scarcity mindset rather than an asset mindset. And that's, to me, one of the fundamental barriers that we as a global society now have when it comes to confronting not just pandemics, but also confronting healthcare disparities in general. And so what happened? After Almaty, we had this vision, but no plan, no funding as a global community. And so the next 10, 20, 30 years, the world, the global health community, including multinational, multilateral organizations, focused on what they called selective primary healthcare. And that was born, I believe, out of really a neoliberal mindset of the 1980s that really devastated many healthcare infrastructure and systems in the emerging global South, especially many countries that had just gained independence, for example, in sub-Saharan Africa, where, for example, Gobi FFF, and many of my colleagues here may have seen this in action, the 7 interventions that were, quote unquote, the most cost effective, the least costly, least or most likely to be funded by global donors on the order of a few dollars per person per year, which did not require any investment in health systems or true primary care. And then in the last 10 years, there has been now a movement, a reimagining of what Almaty could be now in the 21st century, and that's the Universal Health Coverage Movement, UHC, and that has been a big focus over the last some years now. But again, when we are now confronted with COVID-19, the global community, in my mind, the global health community still has a very much deficit-minded mindset rather than a mindset where there is plenty of resources out there where everybody can get vaccine, rather than some countries, what I would consider hoarding vaccines. So the lessons, again, from the past several decades of global health are truly that we have not gotten over the fact that we are focused on scarcity rather than abundance. So, how do we change that? How do we change that? So this Venn diagram shows where the reasons why we should have a focus on, for example, treating everybody for with COVID vaccine, making sure that everybody has access to healthcare. Some people say, well, it's a security threat. You have to preserve yourself, and every nation has that responsibility, including global North nations. And in order to preserve yourself, you have to somehow help other people in order to do that. While other entities, so for example, maybe the World Bank or multinational organizations, think that economic development is predicated on good health for the population. And then finally, there are, of course, many of us, and I hope many, all of you on this call would agree that from a pure equity standpoint, that mandates that we focus on everybody in terms of COVID vaccine response. But oftentimes that leads to problems with pragmatism. And so this Venn diagram, where the convergence of these three kind of reasons for pursuing global health equity, that's where I think we have opportunities where all the major players, the power players in the global north especially, can agree that yes, in this convergence, when there is a impact on security, economic impact, and of course health equity impact, then that's where we can all work together. Just sort of a quick slide on this idea of how much money actually goes into direct assistance for health, development assistance for health. This is from the IHME over the past 30 years. The amount of funding for global health has essentially quadrupled, but it's plateaued in the last decade or so. But this amount of money, 40 billion or so per year in DAH, has translated to millions and millions of lives saved. This little amount of money compared to what the world is spending, indeed, what the US is wasting in healthcare services on an annual basis. This data is from the IOM here in the US, or what's lost due to lost revenue in the tourism industry, for example. It's really pennies on the dollar if we were to really focus on taking our vast resources and really making an investment, whether you think it's because of an economic reason that you're doing it, or a self-preservation reason, or you have a moral obligation, and that mandate from an ethical standpoint or from a reparation standpoint. This convergence is what actually brings all these players together. So I'm going to stop there and just say, what global health looks like now, from Almata to Gobi FFF to UHC and COVID-19, it demands an asset-framed response. It demands a response where we focus on systems at all levels, focusing on at the village level all the way to the national level. And I think one thing I didn't mention, and I hope others will mention, is that these systems have to be strong enough to respond in a way that is extremely timely. We definitely saw that speed is of the utmost importance during this pandemic, that the nature of this pandemic, and I can guarantee that the nature of future pandemics is that we need to act relatively quickly, and actually more quickly than we have in the past year and a half as it relates to stopping the spread of COVID. And that requires deep investment in health systems at all levels. So I will pass it on to the next speaker, and I look forward to this conversation. Thank you.
Thank you. I'm just going to share my slides. Many thanks for the introduction, Professor Zaman, and thanks for inviting us, Dean Galea. So I'm going to present briefly. I'm going to address the two questions that Professor Galea asked us to address also. So first, I think a bit more of a personal comment, and also maybe perhaps for the students from the University of Boston that are attending, looking at what challenges and opportunities did COVID exposed in your field. So my field of work is on health systems within global health, on health systems and health policy. And we have been working on specifically on health systems resilience, which is more related to COVID-19. And we were looking at understanding and responding how health systems can respond to shocks. And for that, we've been working around 12 years, coming from the perspective of first, the financial crisis. We looked as a shock, then we also looked at migration, and we also looked at Ebola. And I think here it's quite clear one of the kind of phases that we go through in resilience. So first of all, of course, planning is crucial. then it's this idea that the health system has to absorb the shock and then to recover and adapt. And within here, we always emphasize a lot monitoring and evaluation, which I think has been massively missing in this pandemic. In terms of the work that we did, in terms of the challenges, so I have a small team in Singapore, but also I'm from Spain, and I'm currently work a lot in Europe. So I've been transitioning between the two continents, and sometimes being quite surprised about the different policies and the different strategies that have been followed. To the point that when I'm discussing now with my team in Singapore, sometimes it's quite challenging to even be empathetic with my team, because sometimes they come with concerns like we are very worried in Singapore because now we've got the Delta variant and we've got 50 cases today, when in my country where I'm based, at that time we had 10 times or even more number of cases and a greater number of deaths. So these are the challenges of working across continents. In terms of the work, it was very clear from the dean of our school that he came to me like late December, and he said, Elena, would it be okay if you move all your team to work towards COVID if possible? So that was a bit of a challenge, but of course, we understood that it was really important. And the first paper that we worked on was this idea that although everybody was focusing a lot at the beginning on what's going to happen in low middle income countries, there was already a sense in Asia of what's going to happen to high performing countries in Europe. And that's why the dean of my school asked me if I could get the best experts and write a comment already comparing Hong Kong, Singapore, and Japan and what other countries could learn. After that, trying to contribute with health systems resilience work, and also documenting countries that we believe, at least in the first year, had interesting experiences for other countries to be inspired and to learn. And perhaps here you've got the paper in Singapore, but also not so spoken, but I think really good case study of Taiwan. After that work, we're moving into the learning from restrictions. As I said, we realized that European countries and Asian countries could learn from each other. Perhaps more European countries learn from Asian countries, but again, we built up a team of experts in 9 countries, and we produced a paper to discuss what were the strategies to follow. So this more at the personal level, this was the type of work that I was doing until then I was asked to join the independent panel, which has been for me the last 9 months. It has been an honor working together with as a member of the Secretariat, and I'm very much aware that there's also colleagues at Boston that they were involved, including Salma Abdallah, which has been a pleasure to work with her. And just to highlight here the independent panel, I'm sure you're all aware, it's chaired by Helen Clark and Madame Shirley. We have the panel members, the Secretariat collecting the evidence. And as a process, I think in itself, we should write a paper on that, because this is the key on how do we evaluate the international response and also other lessons learned for countries, because one of our recommendations is also that countries should start evaluating the responses. Very complex process, lots of people involved in the Secretariat also, and some of the younger researchers also collecting the evidence. We conducted interviews, roundtables, exchanges, and it was this idea also of involving the community and for people to be able to provide submissions and their ideas. And here you see we had more than 140 submissions. But at the same time, knowing that this is a political process, it was very key also to involve prime ministers at the highest levels. We produced, one of the key outputs was also to produce the chronology, but we also, of course, look at the global health system and some of the recommendations. And also I was responsible for managing work in terms of 28 countries and looking at the responses and what we can learn from that. So very quickly, in terms of the findings, what we saw is that despite the warnings, the world was not prepared. And I think the biggest point here would be that we had already we identified 12 processes similar to ours for SARS, for Ebola, and most of those recommendations had been ignored. I think this is a key lesson that we have to avoid for the next one. And this is the key message in our report is, okay, we did not listen before. This time we need to listen to the recommendations and implement them. I think academically, one of the key challenges also was the fact that we were not able to measure very well whether countries were prepared or not. So this is something to consider for future pandemic preparedness. In terms of the country responses, we produced, as I said, an analysis of 28 countries. We produced a new framework on health systems resilience, taking into account the health system, considering it in a broader context, including governance and collaboration across sectors. I won't go into detail in that, but this would be to highlight some of the key aspects that we identified that work for us to take into account. And very briefly, previous partnerships and previous preparedness plans had helped, but especially trust in science, commitment of politicians to work with the scientific advice, having strong leadership, governance approaches, and also having leaders that were empathetic and willing to listen. But of course, then you also need to have strong health systems that have been depleted in many countries through austerity measures, have strong public health. And what we did identify also very important to have economic and social support for all those public measures that lots of countries have not done that yet. This work is much more complex, but now moving into the recommendations, of course, one of the key aspects that has been mentioned by the other speakers is the issue of inequities and the social determinants, and exploring also the social determinants of health, which the University of Boston is very strong on that. And here, again, we all agree that this is not appropriate, the situation that we have right now, when only 2% of people, this is from today's data in low-income countries, have received one dose of the vaccine. In terms of recommendations, last two slides, at national level, we realize that the ones that we all talk about in terms of public health interventions, immediate actions, and risk communications is only the tip of the iceberg. And we suggest that we really need to change at the societal level to address, as we said, to build equitable societies, shift mindsets. In terms of research, we need to invest much more in multidisciplinary research. And one area that we identified is the need to integrate the health system, primary health care, and long-term care social protection. That we've seen many countries have suffered a lot from that. And of course, a key area is we need informed leaders, and we need independent decision-making. The countries that have managed to do that have been much more successful. And overall, a whole of society, whole of government approach. Of course, you might be aware that we have a huge set of recommendations at the international level for the report. And just to highlight the need for some immediate actions, which is sharing of 1 billion doses to COVAX. So the vaccine is a key priority. One of our key recommendations is to elevate the leadership at global health above WHO, and we propose a council of leaders. Of course, we suggest that strengthen WHO. We need to invest in preparedness now. We also suggest to establish a new global surveillance system and a pre-negotiated platform for tools and supplies, and a new international financing for global public goods mechanism. And overall, as I said, we also need effective national coordination, and we need to evaluate those responses. We're very strong on that point. Also at the national level, it came up very strong. So in summary, these are some of the recommendations. We can get into the details at the question time. So many thanks for your attention. And now I'll stop share and I'll hand over to the next speaker.
Thank you, Elena. I think I'm the next speaker, unless I'm wrong.
Yes.
You are. Please go ahead.
I am. Okay, fantastic. Elena, happy to know that you're Spanish as well. So me too. Wonderful. Dean Galea and team and all of the participants, I'm so pleased to have this opportunity to share with you. And of course, I fully agree with the recommendations and the proposals made by the previous speakers, all very, very much in line with what we have been discussing and what it will represent. Not the new normal. I think we should not be modest and ask for a new normal, but a better normal, a much better normal. And I think if you ask me about the challenges, I think one of the big challenges for this better normal will be to use our intelligence, and particularly to use our common sense, and make sure that while we implement all the recommendations that have been made and in a very systematic way by Elena in terms of reinforcing our capacity for epidemic preparedness and response, making sure that our firefighters are well prepared with a very good system, a very good surveillance system. We need to be more on solidarity, on equity, and better universal health coverage. We need to make sure that we integrate, we ask all of our systems to talk. We need to have a holistic approach to the response and making sure that we do not lose time. But at the same time, we are preparing for a potential new pandemic of a SARS or a coronavirus or any other virus. We need to realize as well that there are other crises that are happening at the moment. And this one that is the society is not prepared for yet another alert, another concern about their public health. But the moment we will finish the coronavirus pandemic, I'm afraid we need to start very seriously, even now, to deal with the climate change, which will be probably one of the biggest public health challenges we are facing as well. So that's why I mentioned that one of the best ways to start a new normal will be to repair. We need to repair all the structural failures that we have identified at the moment as well. And they took us to the situation where we are, and they made us as a society so vulnerable. Why we were so vulnerable to this virus? For different reasons. But those reasons are the prescriptions or the recommendations that we need to put in place as well, in addition to the ones to reinforce this epidemic and preparedness and response. We need to address those causes. And for that, we need several things to repair. One, stop our fight with ecosystems. I think we need to recognize that unless we stop polluting everything we touch, the food we eat, the water we drink, or the air we breathe, we will be on a very vulnerable position that will facilitate the spread of any virus, or will facilitate definitely, it will create more vulnerability for any other global health crisis. So investing on realizing that if we keep fighting with nature, with ecosystem, with biodiversity, we will be the losers. And only by repairing this relationship with our ecosystems and biodiversity, we will be able to reduce our vulnerability. And this is a wise investment. The governments are at the moment, many governments are at the moment putting a lot of financial resources into this recovery after COVID-19. We need to make sure that this financial support is going into the right direction and not making the same mistakes that we have been making until now, because then otherwise it will be one virus or a bacteria, or will be again another crisis like climate change that we are facing at the moment. So repairing this relationship with nature will be one of the best things we can do, and directing our investments to stop that pollution will be a very way to move on that. The second prescription, or the second thing that in our opinion will contribute to this healthy and green better recovery is the question of, we need to finally take advantage of this situation to solve the terrible situation that most of our population is exposed to. One of the most important recommendations, the basic public health recommendations we were making during the pandemic, was wash your hands. Well, it's a very simple recommendation. For 3 people every 10 around the world, this becomes something absolutely impossible. They don't have the capacity to wash their hands or have access to sanitation or hygiene services or soap. So it's time now, with those fundamental and fantastic financial investments, to repair again another structural failure that again will put us in a very vulnerable situation for any virus, bacteria that can occur. If you don't have sanitation, if you don't have access to safe water, if you don't have on a healthcare facility the possibility of wash your hands and ensure a minimum of quality of treatment, then we are all vulnerable. And those are very non-regrets investments. Who will disagree that no matter what, if you invest on access to safe water and sanitation and hygiene, you are making a very good investment to prevent many diseases and to create a healthier society. Prescription number 3, and again, common sense, wise, pragmatic, non-regrets, the energy transition. We need to ensure a quick energy transition, healthy energy transition. We need to stop using fossil fuels, the combustion of fossil fuels, and start to use renewable sources of energy, clean sources of energy. The fact that we are using, or we are using fossil fuels and combusting fossil fuels, this represents 7 million premature deaths every year caused by exposure to air pollution. This is already a terrible pandemic. I mean, and in addition to that, if you are breathing polluted air, obviously your lungs will be much more vulnerable to any infectious agent, and particularly a respiratory one. So clearly, go in and then tackle the causes of air pollution. And one of the causes of air pollution is the combustion of fossil fuels, which overlaps on a 75% with the causes of climate change, global warming. Again, this is a very wise and a strong recommendations that we will make for this healthy and green recovery. That will be good for health, it will be good for the economy, will be good for society, and will represent fairness as well and equity. People is spending now hours, women are spending hours now to collect the coal, to collect the wood in order to cook or to heat their house like in the Stone Age. And that represents a terrible mistake for our investment. So stopping the use of those very pollutant fossil fuels will be a very good protection for the new global health. The prescription number 4 will be about how we produce our food. We need a more sustainable food system from the beginning to the end. Only the waste of the food we produce every year, it contributes to the global warming. It represents almost 10% of the greenhouse gases emissions. This is again a nonsense. Unless the public health community at large, we try to infiltrate and influence the way we produce our food on a more sustainable way, we will not put in the basis for a good public health, a global public health, and we will be again very vulnerable. Maybe we will be very good on the response, on the preparedness and outbreak and response, but we are not tackling the causes of all of these iceberg, which are, by the way, the basis of our normal health in any circumstance. The next prescription would be about the cities, the urban design, the healthy urban planning that we needed. At the moment, the cities are not planned for citizens. They are not planned for protecting our health. Cities are urban environments where we cannot walk because the cars are the protagonist of the city, not us. We cannot breathe proper air. We are breathing very polluted air in most of the cities around the world. We are heating our buildings on a very inefficient way. We are not having access to the waste system in most of the places around the world. So building and moving, again, another transition to a healthy urban planning will be a very solid investment, common sense, and again, it will reduce our vulnerability vis-a-vis the possibility of a new virus, whatever the virus will be, or because we don't know what the next crisis will be and how the next crisis will be. We need to put all of those solid things. And the last prescription, I think we put it on our manifesto for a healthy and green recovery is use our taxpayers on a more strategic and public health oriented way. At the moment, we are still giving subsidies to fossil fuels. And when we calculate, when the big economies start calculating those subsidies, they forget a little detail. They didn't consider the externalities of using those fossil fuels subsidies to cause chronic diseases that then our health systems are going to pay. So you invest on subsidies without calculating that it will cost you 3 times more to then repair what the disease that you have caused and to maintain your health system. So those are the 6 prescriptions. Clearly, and I will stop here. Another prescription that I will make, we need to be very strong at the COP26, and that's why in WHO we are preparing the health argument for more climate action, and I will invite all of you to subscribe this report where we give how climate change is affecting our health, but more importantly, how by tackling the causes of climate change, we will be generating and having enormous benefits for our health. And most of those benefits will be fantastic as well to prevent new pandemics or epidemics. And the last one is that obviously, yes, the health systems, they need to be more resilient, better prepared for any crisis that might have, but we can as well, and this is one of the initiatives that the COP26 is proposing for all of you, we can decarbonize our health systems and leading by example somehow, making sure that we have a more efficient use of chemical systems, water resources, electricity, reducing our carbon footprint, obviously in those countries where they are contributing to the carbon footprints. Many countries around the world are still not having access to any source of electricity. So clearly those are the ones that needs to be provided with renewable sources of energy. So plenty of ideas that we could consider for this new global, and I will be happy to answer if people have questions about that. Thank you, Brian.
Thank you so much, colleagues and esteemed panelists. We have lots of questions coming in from different forums. Let me start with one that connects to a discussion we had on this forum with a friend and a colleague, Catherine Flowers, who looks at the challenges faced by African Americans and Black communities, urban waste and sanitation. And I'm reminded by her book that even in countries that seem to sort of have vaccines available, there's a huge disparity. The stateless and the refugees may not get the vaccines. I speak for my own country in Pakistan, that you may have vaccines coming to the country and the country may choose to vaccinate some people and not others. How do we ensure that our strategies are truly inclusive, that people who have been left behind for a long time, refugees, stateless, internally displaced, they are also part of this conversation, that we don't sort of think that our job is done when each country gets it, but rather that each person gets it, needs it. How do we ensure that? And how do we sort of create a new normal which is truly inclusive in that sense, and not inclusive just at the country level, but that at the people level? I encourage anybody who wants to sort of comment on that.
Okay. Do you want me to start maybe? As you know, WHO has been insisting a lot of this issue, on this issue of inequity. I mean, I think this is probably one of the most shocking examples of lack of equity these days on the vaccine distribution. And we saw it as well on the issue of universal health coverage, for instance. If you live in a country where you have free access to your hospital for treatment, if you have COVID-19, you will have it for free and you will have all type of treatments, while in other countries, even very well-developed countries or considered well-developed countries, the people get almost, I mean, they needed to pay it by themselves, and that is an enormous equity. So how we can ensure, I think we need to push for, again, this universal health coverage, equity on the vaccine distribution, and making sure that the rich countries are conscious that now they need to be very solidaire and put more resources into the COVAX for then the countries to redistribute it. But as well, we need to put responsibility on those countries that are receiving the vaccine as a donation, and then they are using it maybe not on the most adequate way, and they distribute it according to their political preferences or their group preferences or any other reasons. And even some corruption is happening as well, no doubt of that. So we need to ensure scrutiny and monitoring as much as possible, and making sure that the groups that are not benefiting, they could complain or at least protest or having a voice to raise this issue.
Great. Elena, and then Conley?
Yes, I'll just answer quickly because I completely agree with Maria Neira's comments. So I think one of the challenges that we identified is that particularly with the financial crisis and the austerity measures implemented, many countries that had universal health coverage started excluding migrants and refugees from the health systems. So I think this is a key challenge, and COVID has illustrated exactly this fact, that we were going, rather than being more inclusive, countries are starting to be more exclusive. And I think we need to highlight that and reverse it. And a lot of us have been working with NGOs also, like Doctors of the World, to try to reverse that trend and to put pressure on governments. A second point is more general, that also, of course, COVID has highlighted the issue of inequalities. And I wanted to mention the case of Singapore, because it's where I'm based and it's where everything started. So you have a pandemic that has very much control, but it showed that the cases were escalating within migrant populations. And it showed that we cannot have migrants living in such poor conditions. So I think on the positive note, there has been awareness and the situation is going to change, but I think we need to continue with that line and not forget once the epidemic is over to continue excluding migrants and refugees from health systems and continue for them to live in such poor conditions. Thank you.
Great. Thank you so much. Conley and then Dr. Lay.
Yeah, so I mean, my comment is really related to what has been said already. I think we often focus on what we see. So we're able to see that vaccine benefits disproportionately benefit maybe one group over the other. But it's important for us not to forget that it's COVID today. It could be another thing tomorrow. As long as those underlying causes are not addressed, we're actually just moving, we're just changing faces, but we're not solving the problem. I think it's important to think about a more inclusive health system, particularly that guarantees some of the social determinants of health for all groups. And I think we should be able to see the connectedness of those efforts to addressing global security, to addressing maternal health and child issues, to addressing all health issues, because it's really, once you empower people, they're able to make choices themselves, they're able to delegate resources, because think about why the immigrant will not come forward to take the vaccine. Maybe he or she is afraid that they're going to be thrown out of the country, and until you address that, even if you take the vaccine to the person, until you address that fundamental fear that the individual has within that system, you're just going to move you're not really solving the problem. You're just temporizing on it.
Okay.
Thank you. I'll just tell a quick story about an underserved community here in the U.S., which is the Native American community, and this is served by IHS, which is the Indian Health Service. I'm the medical director of a small clinic that serves about 2,000 Native Americans in a Northern California tribe. And the vaccine at UCSF, where I'm faculty, we received it, I believe, on December 16th. Well, on December 17th, we received it in that clinic through a different mechanism. So when you mention, are there ways to get the most underserved people access right away? Yes, there are, definitely. And why does it exist in places, in some places in the US? It's because the health systems are already present. And so I would say that, if there was an IDP camp or refugee camp where there's no health system, then I think it would be really challenging for you to deploy vaccines equitably. And so, yes, the point about having an ongoing health system strengthening effort, of course, is one of the answers. But also, to address 190 plus countries, different political systems and different health systems. I might look at the Global Fund and how they distribute funds, and they force, for example, through the CCM mechanism, they force civil society and the public sector and nonprofits to work together in order to receive those funds. And similarly, I think that a similar model may work for vaccine distribution, so that the systems are already present, even if it's an IDP camp or a refugee camp, that is, or a migratory community, or a community dealing with homelessness. Still, health systems can still be built, and we've done it in many places, at least here in California, where I'm sitting. And I think for sure that if we use like I mentioned again, an asset mindset, an asset-based framework to use the people who are there, the local leaders and the local community. That's a way to really ensure bottom-up and top-down approaches to the next pandemic.
Thank you so much. Lots of questions, and I'll try to start from the top if I could. And please feel free to answer whoever wants to do that in whatever order. Certainly not everybody may want to answer every question. So I'll read the first one from Helen. What are the ways the healthcare organizations and individuals can identify and collaborate on larger issues around infodemic in both global and local communities? Are there organizations that are leading on this effort? Certainly this issue of of conspiracy theories or anti-vaccination campaigns, misinformation, a huge issue. So anybody who wants to sort of take that, doesn't have to be in any order.
Yeah,
Go
I'd
ahead.
like to.
Yeah, go ahead,
Yeah.
please.
Yeah, so I think just quickly, one, the answer to misinformation and disinformation is the right information. So I think it's important to have the right to have authoritative sources engaging the population and engaging people. And I think we should not shy away from really working with the social media and really formulating active strategy to regulate in some ways the kind of information that are disseminated. And this is not just limited to the US or to Western societies. I think even in Nigeria, in other societies, we find that the disinformation as it plays out here in the US is playing out in other places as well. And I think we should be thinking about the future of global health. Future global leaders. So some of our students that we're training now, some of us that were coming up in global health, I think we need to think about how we train people. We need to rethink how we train people. We are living in a society where you're not just, for you to be a successful global health practitioner, you really have to be able to listen socially. You have to be able to engage community with the right information. We have to use the masses of people to be able to engage within those media to give the right information. And I think there are a couple of countries that are doing that. I also know that the WHO, the UNICEF, for instance, has some frameworks around that as well. But I think as an academic community, university, we need to train people with some of those soft skills to be able to engage in the social environment.
Elena.
Yes, so following on that point, I think it's very important, and this the BMJ has actually commissioned a special issue on that, where we contributed a paper on production of knowledge. So it's this realization that now it's not enough to either produce knowledge without involving the community in terms of planning the research, but also in terms of having committees to involve them when you conduct the specific research, but also co-production of knowledge in involving the community in decision-making processes. And I think COVID has highlighted this challenge very well, where countries that have not involved the community in the provision in risk communication, they have in many cases failed. And we see exceptions and countries that have done really well in doing that, and they have shown the way. And one of the key examples has been in Nigeria, but also Thailand, where the community has been involved in the planning of the messages. And I think an area that we failed was that to involve the younger people in many countries. And I think we could have done much better there to ask them to organize focus groups and say, okay, how can we go about the measures in you being listened to, and then to implement them, because it has been one of the key challenges.
Great. One of the questions that was asked by Onosoreme Ofoman to you, Dr. Conley, you mentioned the potential usefulness of creating an independent, adequately funded multinational committee that takes on efficiently disseminate data. Why haven't we been able to do that already?
That's a $1 million question. I'm sure people here would have a lot of insight to that. But when I think about why we're not able to work effectively as we should, I think about incentives and disincentives. I think one of the major challenges is that we've not seen, that's my view, it's my opinion, that at the very top, we've really not seen the incentive, or it has not been made clear, the incentive that our common survivor really depend on all of us working together as one. I don't think that message has been made very clear. And so we are still competing rather than cooperating. And again, there's a lot of tension, geopolitical tension, and people protect their national interest. And of course, that's understandable given the nature of inequity. People are willing to address inequity that they see that it's going to serve at least a common interest up to a point. So I think that one of the challenges is really the lack of incentive for true global solidarity and cooperation. And I think the solution is really we really need to engage leaders. We need to engage leaders at all levels to begin to see that it's to all of our common good when we have such accountable structures, when we have such transparent structures, because it might not look beneficial to them, to politicians, for instance, in the short term, but in the long term, for the common survival for advancement of the human race, it's really something that is key.
Thank you. Next couple of questions, I want to combine them, focusing on renewable energy, fossil fuels, something that Maria, you had mentioned. A couple of students had asked, or I'm assuming students, a couple of attendees, my apologies, had asked, what is the role of building healthcare systems that actually run on renewable energy? And isn't it a tall political order when the political appetite for these isn't quite there? So we want to build new health systems that focus on renewable energy, but the political appetite for even doing some of the most basic things isn't there. So how do we sort of energize both the health community and the political community? I'll go to you, Maria, since you mentioned sort of renewable energy and COP26.
Yeah, thank you. It's a very, very good question. In fact, to respond to that question that we were asking ourselves all the time as well, how can we make sure that the health system and the health community will talk with the energy community or the ecological transition, or depending on the country, how can we make sure that they will talk? So we have created a platform for health and energy at WHO, where we put ministers of energy and ministers of health, and we provide all the scientific evidence we have about how the different sources of energy will impact negatively or positive on the health of the people. So we use the health argument to propose a speedy and a logic transition to more renewable sources of energy. And then we facilitate as well access to different technologies, exchanges with other countries. What are the experiences now? For instance, we are working with Gavi. Let me give you something to I think it's an example, but it's so visual. At the moment, we have Gavi providing vaccines, for many countries around the world, or we have the polio eradication, or we have the global program on HIV, AIDS, and malaria. Most of them, because the health systems, the healthcare facilities, they do not have electricity, they cannot have a little refrigerator to keep the vaccine cool. So they need to provide solar panels for one refrigerator for having their own vaccine. So our idea now, and this is the project that we are engaging with Gavi and UNICEF and others, is upgrade the capacity of this solar panel for your refrigerator where you keep your vaccine. And at least by doing so, you will have enough solar panel capacity, energy capacity for the whole healthcare facility. And by doing so, you might create as well a model and a system that will, in those places where you don't have access to electricity, you will provide the resources needed and the solution needed. And I think that the appetite has to come from the national authorities, no doubt. They should disinvest on particularly developing countries. They should learn from others that this is not a good investment. They have incredible sources of solar energy and in many places, and we are still, creating this system where fossil fuels are still generating even political distress and many other associated problems.
Thank you. I'll take two more questions. Dr. Lay, I was going to direct the next question to you as well, so perhaps you could answer both. Macy asks, what role do you believe primary and secondary education plays in accepting scientific and medical information? Due to lack of standardization and equity in the quality of education, we see lower vaccination rates in lower socioeconomic school districts. I'll tell you a little story as well. I worked very closely with a high school in Bronx, and one of the students who was brilliant asked me that there's a distrust of government. How do you know this is not another Tuskegee? She's not a vaccine denier, but she's worried that there is a huge historical trauma associated with vulnerable and marginalized communities. And they are then much more reluctant to accept the government's policies because of the past, which we cannot deny. So this issue of socioeconomic disparity and vaccination, education, equity, how do you sort of equate that, and also sort of this question on energy and sustainability? So please go ahead.
Yeah, thank you. I definitely agree with Maria's points. I just want to point out the fact that I wouldn't want to say that it's the burden of LMICs, low and middle income country nations and their governments, to say that it's their job to build a health system that is based on renewable energy, when the global north has not even, who has polluted this planet on an order of 100 times as much as any LMIC maybe combined, is not even close to getting there. And so if you want LMICs to do it, well, it's a pretty clear ask that the global north countries must pay for it. And otherwise, why would LMICs, ministers of finance, spend additional money when fossil fuels are cheaper, if they are cheaper? And so, yeah, I just don't want people to get distracted and not really go to where the source of the pollution is, which is North America and Europe and China and the Indian subcontinent. I mean, those are in terms of sources of fossil fuel burning. Okay, so I'll get to now your question, your student's question about education. Yeah, I mean, everybody brings up Tuskegee. If you're a Black person in the U.S., you'll hear about Tuskegee. But we just need to be careful and understand that the range of reasons why people don't get vaccines is just enormous. And like I said, I'm a medical director of a tribal, a native-run clinic where we have very low vaccination rates. But yet there are 570 something federally recognized tribes in the U.S., and the vaccination rates are different for every single tribe. And even within my own, patient community, whenever I ask a patient why they don't want to get vaccinated, the reasons are extremely different. It's not uniform. And so while I absolutely understand why there is a correlate, that there is an association between education level potentially or quality of education perceived and the amount of vaccinations, I would be careful for people to say that that's a causative phenomenon. It may be an association that is due to other things, to structural causes. Access could be one. So I want to be careful that people to not say that education is the answer. There are plenty of very well-educated people who are not accepting vaccination for one reason or another. That gets back to your previous question about misinformation and social media. So clearly, education is an important thing, but I don't want that for people to feel like it's the causative, it's the root cause.
Thank you so much. We have about a few minutes left. I want to ask all of our panelists 1 minute each on advice to students. We have a number of students who are joining, and a couple of students asked that, sort of the new rising workforce and the practitioners and the future leaders. We'll start in no particular order as I see them on my screen. Dr. Lei, you come up first on my screen, and then Maria, okay. Dr. Conley, and then Elena. Just 1 minute each advice.
So advice to students, I think what I've learned over the past 20 years in academia, one of the key aspects or perhaps the best aspect that I had in my case was having a great mentor. And I had few mentors before having a great mentor, like bosses mentor. I had a few bosses that they were not so great. And then when I found a great mentor, I was like, wow, things change a lot. so be very wise when you're looking for a job in terms of work with nice people and pay attention to that, to whether they promote the younger generation, whether they give opportunities, and whether they give you the chance to publish in high impact factor journals. That's key in a career. And this is very easy to spot on, whether you see that the big bosses are not the first offers or the last offers. So that's what I've learned over the career. Great mentor, good boss at the beginning helps a lot. And then, of course, try to get involved in opportunities where you can work together as a group, and in many networks now that are emerging in terms of identifying young leaders. And it takes a bit of time, but try to talk to the right people and get involved in this type of initiatives.
Dr. Lay?
Thank you, and I'm just going to put my email here for everybody. If I love talking to students and tell students all the mistakes I made and try find ways to avoid them yourselves. I would say that if you're a student, you're going out and you're starting, go and ask the question, what's strong with the community, before asking what's wrong with the community. That's asset thinking rather than deficit thinking. Go into, if you're interested in working with a specific community, ask yourself and the community, what is strong, and use that as the first point to step off into an intervention. If you have a lived experience where you are, by identity, perceived identity or personal identity, you feel like you're part of an underserved or an oppressed community, that's where you will make the most impact. Rather than reinventing colonial dynamics by being a privileged person going into a very underprivileged community. If your lived-in experience is being underprivileged, that's where you're going to be making the most impact. And definitely work at the very most local level before working your way, quote unquote, to the next level at either in academia or in Geneva or wherever it is. Know what it's like to be among people who are suffering and being oppressed on a daily basis.
Great. Maria, advice for students.
I think in addition to the very wise advice that you got already, I think I will add that as a student today, you need to be prepared when you will be a professional to influence. Don't accept only to treat patients. If you want to work on global health, remember that it's not just the disease we need to deal with. We need to look at what caused the disease and how can you prevent the disease. Something as basic as primary prevention is something that we are not investing anymore on primary prevention. So don't be shy, be prepared to influence anyone that will have a capacity to provoke or create or impact negatively health. Be ready to discuss with ministers of energy, ministers of environment, ministers of communities, whatever is needed, provided you go to the source of the causes of the diseases and make sure that you talk about health, not about disease only. This view, holistic view and context will be very, very much needed if you want to do public health. So don't accept anyone to say, this is your business, don't mess up with others. Be prepared to mess up and to be a little bit revolutionary and work, yes, with the community and understand what you can obtain from them.
Great. Lastly,
I think to add to all of the very wise advice, I think it's important for you to know your training continues. Particularly, there are soft skills that I can speak for myself. I wasn't trained on how to negotiate, on how to listen and all of that. And to be able to do some of those things that Maria is saying, you really need to be prepared and to be equipped with the right skill. Public health is changing, global health is changing. There's a lot that we need to still unpack in the way we train in terms of engaging people and influencing people. And there are lessons we can learn from other discipline and paradigm. Be open to learning and to new learnings, particularly skills that can help you to influence others. And be open again in terms of the pathway. Sometimes you know exactly what you want, you are mission focused. Other times the mission chooses you. So you really have to be open. You'll be surprised that where the platform that you don't see now might actually be the answer to the solution that you're trying to implement. Thanks.
Thank you so much. Over to you, Dr. Dean Galea.
What a really fantastic conversation. I learned so much from all of you. I was thinking that when we created this series, we charged the speakers with really envisioning the challenges and issues in the field, and you all did that wonderfully. I think there is perhaps no topic that's more interesting right now than global health and the future of global health and the next normal in global health. And you have all given me so much to think about, and our audience so much to think about. So I'm grateful to you all. I want to say thank you. Thank you for taking the time. Thank you for thinking about this. And I want to say thank you to our audience. Actually, we had some excellent questions from our audience. And thank you to Professor Zaman for excellent facilitation. Everybody, with gratitude for what you do and with excitement actually for what we will learn in coming years and decades and how our thinking will evolve. Everybody, have a good afternoon, a good evening.